Thanks very much, Tahani, and welcome everyone. We're so pleased to be able to bring you this webinar. I'm going to spend the next few minutes just giving you a little bit of background of why AHRQ might be interested in sponsoring a webinar on shared decision making and particularly emphasizing in patients with low health literacy. First of all, for those of you who are not familiar with AHRQ, we are a federal agency that is part of the U.S. Department of Health and Human Services. And our mission is to produce and disseminate evidence to make healthcare safer, better quality, more accessible, equitable, and affordable. Back in 2013, we began an initiative called the SHARE approach, where we developed a 5-step process to help clinicians work with patients together to make the best possible healthcare decisions. And you see on your screen each of the steps delineated, and there is a URL towards the bottom of the page on the right-hand side of where you can access more information about the SHARE approach. And we've been working to spread information about this, including having created a series of tools that can be used by healthcare organizations and clinicians to help implement shared decision-making in your setting. In addition, we've been hosting one-day train-the-trainer workshops around the country. These are free, and you see there that there is a URL for registering for those meetings. You should have received a copy of these slides via email, and if you look at them in slide mode and click on that URL, it will take you to the registration site. In addition, AHRQ has also had a long program in health literacy improvement. And so here I'm just highlighting a couple of our tools that are used. The AHRQ Health Literacy Universal Precautions Toolkit that consists of 21 tools in its second edition. These are very short, practical action steps for how to improve different areas: verbal communication, written communication, self-management support. And it also has a companion guide to help either health literacy team leaders or practice improvement coaches to implement these universal precautions. And you'll hear more in the webinar about what health literacy universal precautions are. And the other tool here is called the PMAT, the Patient Education Materials Assessment Tool, and that's used to assess how understandable and how actionable written materials and multimedia materials are. So this is our 4th webinar in a series on the SHARE approach. This webinar, as you heard, is being recorded, and in about 3 to 4 weeks, you will be able to listen to the recording of the audio. We will also be sending again an email after the webinar with the slide set, which will also be downloadable from the website. So lots of ways to access these presentations. You can tell your colleagues who were unable to join us today that they too can hear this. So we are offering this webinar for continuing medical education, and therefore want to make sure that you know about any disclosures. Only one of our presenters today has any disclosures. Mary Politi will be discussing those when she presents in just a few minutes. So our objectives today are, our hope is that all of you, by the time we're done, would be able to explain the value of shared decision-making, and particularly with individuals with limited health literacy, to identify challenges and to work to overcome those challenges, to be able to describe a user-centered framework, which we will be describing to you, to support shared decision-making between providers and patients with limited health literacy skills, and to explain the use of decision aids and how they can facilitate shared decision-making. So we also want you to know that we will be giving you instructions at the end of this webinar about how to claim your CME or CE credit. So if you are receiving credit, please stay to the bitter end and we'll get those instructions to you. We have 2 presentations today, and we will have both of our speakers make their presentations before we take questions. But we want you to be writing down your questions throughout the presentations. So we will not be opening up microphones. You will not be able to verbally ask your questions. So please go to the Q&A box. It's a panel on your right-hand side, and open that and type your questions into that panel. And please, there's a little drop-down menu there. Make sure that the all panelists is showing in that menu. You might actually have to scroll up to get to that selection. And then select send to send it. And I will be reading those questions aloud at the end, and we've allowed a lot of time for discussion, so please keep those questions coming throughout our presentation. So our first speaker today is Mary Politi, and she is a clinical psychologist and an associate professor in the Division of Public Health Sciences in the Department of Surgery at Washington University, St. Louis. Her work aims to help patients and the public understand health information, explore what's important to them when making health decisions, and collaborate to make evidence-informed decisions that meet their needs. She also works with healthcare professionals, public health advocates, and members of the public interested in training in shared decision-making and patient engagement into health. Her research includes a focus on eliminating health disparities by engaging communities with unmet health needs and including them in both research and dissemination efforts. So I'm going to hand over the presentation responsibilities to Mary. I'm having a little technical difficulty. There we go. Mary, you should have the slides. Take it away.
Thank you so much, Cindy. Thank you all for joining. I'm looking forward to hearing the discussions at the end. So my presentation will be focusing on implementing shared decision-making in populations with limited health literacy. I know we mentioned this earlier, but I have some disclosures that are unrelated to the topic of this presentation or the funding for this presentation. Shared decision-making, as described before, is a process by which decisions are made collaboratively by clinicians and patients. They're informed by the best evidence available and also made considering patients' characteristics and values. So a lot of people wonder if this is evidence-based medicine. This is absolutely evidence-based medicine, taking into account patients' unique characteristics and preferences. Why not just make a recommendation? Well, most of what we do in medicine is actually of unknown or uncertain effectiveness. Over 50% of randomized clinical trials for treatments that have been studied by the BMJ's Clinical Effectiveness Series are really uncertain in terms of how it will benefit individual patients. And there's additional 7% that involve trade-offs between benefits and harms. But even the things that we know that are beneficial or likely to be beneficial overall for the population may have some challenges for individual patients in the room. So I'll be giving some examples of situations that you might not think initially are appropriate for shared decision-making until patients actually describe what's going on in their life. And this is particularly true with populations with low health literacy, who may question things that you don't think of as something that's discussed or debated in the field. Shared decision-making is actually often described as this meeting between experts or a collaboration between a practitioner and a patient who each bring different skills and knowledge to the table. So the practitioner may take the first step in inviting the patient to participate and presenting some options, while the patient needs to take a step to describe his or her experience with their health symptoms, their history, maybe their family history. And that can actually then lead back to the provider discussing some risks and benefits and alternatives and uncertainties based on what the patient has presented as well as the evidence that the practitioner is aware of. The patient, in turn, then can share some values and preferences and perhaps some implementation concerns and maybe their preferred style of engaging in the decision-making now that they're aware of the uncertainties and the options at stake. And the practitioner can help this process by eliciting some questions and about values and preferences if the patient is not necessarily as forthcoming or comfortable communicating up front. The practitioner can also check for understanding and ensure that the patient is grasping the complexity of the decision and talk about some possible next steps. So at each step, the patient is invited to and engages in decision-making at their desired level. I'm just going to provide a few examples of how this actually sounds in practice, because sometimes people think, oh, I'm doing this already. The Foundation for Informed Medical Decisions actually has a really great PDF document that has some sample language for each step of the shared decision-making continuum. Sometimes the choice is not as clear as people think. Let's work together so we can find a choice that's right for you. As you think about these options, what's important to you? I want to make sure I understand what you care about. Is there any more information you need? And you have time to think things through. Sometimes people don't realize that they don't have to make a decision right then and there. Are you leaning towards one option or another? So these are not necessarily long sentences or things that take a lot of extra time in the consultation. It's just a different way of eliciting information from patients. Health literacy plays a huge role in patients' ability and comfort communicating with their providers, and it encompasses several different components that are relevant to shared decision-making. So there's conceptual knowledge. There's also oral literacy, or the ability to listen and speak and communicate about information orally. There's print literacy that involves reading and writing skills. And then there's numeracy, or ability to work with numbers. And each of these components are relevant to the shared decision-making process. And so one of the key questions in the field is, how can we lower some of these health literacy demands of shared decision-making? And I'm going to talk about two ways to do this, one through interpersonal communication skills and also through decision coaching. And Dr. LeBlanc, who will follow this presentation, will talk about the use of decision aids to help this process. So as we think about sources of vulnerability for patients, health literacy challenges are really only one source of vulnerability that can impact treatment decision-making. Patients also may have health vulnerabilities, unmet health needs, chronic conditions, or acute conditions without a full understanding of where to go or how to treat them. They may also have resource-driven vulnerabilities, limited income, or family circumstances that might limit their ability to implement some care options. And some of these are unique, and some of them overlap with the other components that might make it more difficult for patients to think about some of the decisions we offer them. So when we think about when shared decision-making is appropriate, most people think, well, it's clearly appropriate when there's no clear choice from a health perspective, or situations that are often described as clinical equipoise. But there are also situations that clinicians might think they have a clear answer. For example, situations of potential overuse, where the Choosing Wisely campaign has highlighted antibiotics for sinusitis. But patients might come to the room wondering why not. And there's also situations of potential underuse, like vaccination situations, where patients might come to the clinician and think, why? Why are you recommending this across the board? So I want to take one example a little further, and I want you to imagine that you're treating this patient named Tiffany. Tiffany is a new patient who was previously uninsured prior to the ACA, and for the past few days she's had a mild fever, runny nose, fatigue, and chills. Her symptoms are keeping her up at night, and she feels like she's not able to concentrate at work. After a complete history and physical exam, you determine she has a mild virus. You encourage her to monitor her symptoms, and you tell her to call you if her symptoms do not improve within a week. And Tiffany gets a little bit frustrated and asks, well, can't you give me anything like an antibiotic or something to help me sleep? The walk-in clinic where I used to go always did. I can't afford to miss any work, and I need some sleep. Give me something to help me sleep, or some penicillin or something. So I want you to think for a minute about how you might respond to Tiffany in this situation. In a study that we're currently conducting right now, people often mention things like, I would listen to the things that matter to her. I might educate her about the risks and benefits of taking antibiotics. I might build some rapport with her. I might respond to her questions and concerns. I might debate the issue or attempt to discredit some of her information sources. And some people even felt I might refer her to a colleague. I just don't have the time to deal with a patient like this in my practice. Or schedule another appointment to maybe revisit this decision. And now I want you to think for a minute about how you might feel about her. Those were behaviors that people might do in response, but what are you thinking? What are you feeling about her as your patient? In the same study, people mentioned things like, well, I respect her decision here to request antibiotics, and I feel comfortable talking to her about her concerns. And I understand her concerns about her symptoms. They're really distressing symptoms. But some people felt like, I really don't like her. I find her annoying, and I'd be pleased if she didn't come back to my clinic. But Tiffany might be thinking several things. Remember, she may have multiple sources of vulnerability. She might be thinking about her other health conditions. I have too many things to take care of. I have diabetes. I have a heart condition. I just need to get past this. She may not understand the difference between bacteria and viruses. And she may feel like, I have no sick leave, no backup child care. I just took off time to come and see this provider. I'm new to the healthcare system. We don't have a relationship already. This provider really doesn't understand me. Here I am asking for help, and they're dismissing me and telling me to come back next week. And these actual real patient stories, people have told us that they feel like some doctors may misdiagnose them based on their vulnerability. So here's a patient who said, you have some doctors that you can ask them a question, and I honestly think it depends on the kind of insurance you have too, that they'll just tell you, well, it's this, when it could be something else. So some of the risks of miscommunicating or failing to engage in this patient the shared decision-making process is that Tiffany feels frustrated with the system. Maybe she gets labeled as a drug seeker because she's asking for help with her sleep. Maybe she doesn't come back and her other chronic conditions are affected. And maybe she feels like no good doctors take her insurance. And there's multiple different things that could be going on. And without actually sitting and taking the time to explore preferences and talk about what next steps might be, this doesn't necessarily mean a doctor needs to prescribe antibiotics for something that's not useful. But taking the time to explain it to her and to perhaps prescribe things like over-the-counter remedies that might help, sleep, rest, fluids, things like that, and actually meeting her where she is and acknowledging that she's actually come seeking something and explaining some of the information that might help her come to this meeting of experts could actually benefit both patients and providers. So this model for clinical practice has often been described by Elwin and colleagues as taking the first step to explain the need to consider alternatives as a team, really bringing in this notion of team talk about options. And then once people are on board that they're working through this together, that this isn't just a paternalistic provider explaining something to a patient, we can move into describing options and alternatives in more detail. And this can be done with or without decision aids, depending on what's available for that situation. Then moving in towards decision talk that helps patients explore and form their preferences before making a decision. So deliberation is a component of this entire process, working from start to finish. Decision coaching can also help patients participate. There are plenty of people who say, I just don't have time to do all of this in the session. And decision coaching can help prepare patients for office visits where they may know that they're going to talk about something that requires a little bit more knowledge and background from themselves. So decision coaching can help by setting an agenda for what patients want to talk about in the setting, a list of questions that patients want to ask their providers, or some way of assessing how much they know already and how much they need to gain from their providers. And the chance to really think about some of their values and preferences. Values and preferences are often not previously formed in situations that might be new to patients. So having a chance to really think this through in advance of the session can be helpful. One of my favorite forms of decision coaching comes from a colleague, Jeff Belcora, who's developed a note called the scoped note that patients can complete with an assister like a coach or a medical student or a nurse practitioner or somebody that's available in the clinic. And it goes through the situation or questions patients might have about their diagnosis or test reports, the potential choices available, some of the patient's objectives and goals for the consultation, who else might be involved in the decision, any family members or friends or relatives we need to include. How will we evaluate what makes a good decision for you? What are your goals? And what information do you want or need from this session? So the note looks a bit like this, and it can be filled in very open-ended, especially if there's no developed decision aid available for the patient's situation. And this can be accessed from the AHRQ website at the bottom. Decision coaching has been found to increase patients' knowledge and satisfaction with their visit. It can actually increase their confidence in communicating with their providers about decisions, which is really important for patients with limited health literacy skills. It can improve decision quality measures and lead to higher quality questions that patients ask. And it can improve their adherence to some decisions like screening decisions. It can decrease their feelings of conflict about their choice, so how uncertain they feel and whether they feel their values are clear or not. It can decrease their anxiety about their choice, and it can decrease their perceived communication barriers. And clinicians find that it actually helps them spend less time on autopilot and more time tailoring their communication to the patient in the room. They have more confidence that patients will remember the information they describe, especially if there's a form that's used to help with the coaching process. And it overall does not actually increase the consultation time in studies that have looked at this, and it just leads to a different kind of conversation in the room. So a lot of people feel like, well, this sounds great and we support this model, but we're already doing this all the time. But in one of the earliest studies of people, of audio-taped clinical encounters of over 3,000 decisions, only 9% of decisions met the most basic definition of being fully informed when people actually analyzed these audio-recorded encounters. And that included the nature of the decision, the patient's role in decision-making, and some exploration of their preferences. Now, this was in '99, so people wonder, is this still going on? But in a very recent study in 2013 of over 3,000 men aged 50 to 74 who were making decisions and participated in a national health interview survey, over 64% had no shared decision-making as part of their conversation. And only 27% had some partial shared decision-making, 1 to 2 elements. Only 8% of people had a full shared decision-making conversation. And this is true even in specialty settings. Some people feel like, well, maybe it's because these decisions aren't high stakes at the primary care level, and people want to be engaged at the surgical level. But in a study of over 1,000 preoperative elective surgery patients, so this was a surgery that was not medically necessary, it was elective, many people, over 34%, had some deficits in surgical decision-making, and 50% had deficits in advanced care planning, which we know is important for both informed consent and decision-making. And in a study of over 2,700 patients who were aged 40 or older that had discussed anywhere between 1 and 10 decisions with a healthcare provider in the past 2 years, very few patients were asked about their preferences in the following contexts: medications for hypertension, elevated cholesterol, and having mammograms. And overall, across all 10 decisions that were studied, clinicians were much more likely to discuss the pros than the cons. And this is really common. It's not comfortable to tell people that maybe there are some risks involved. We want to instill confidence as providers, but it's not necessarily considered full shared decision-making and full consent if patients aren't aware of some of the drawbacks. Another thing people think, and particularly with patients with limited literacy skills, is what if my patients don't want to be involved? But if we look at national studies of almost 3,000 participants, 96% prefer to be offered some choices, even if they want to defer the final decision-making to their provider. So about half of them say, I still want to defer the final decision, but I want to be offered choices and I want my preferences explored. In invasive medical procedures, about 80% have wanted shared decision-making or some patient-led decision-making, and 93% want clinicians to share risk information. Only 3 to 8% say they want no role in decision-making at all. So we've argued that perhaps asking patients their preferences and patients stating things like, my preferences are to cure this disease as quickly as possible, but I'd like to continue working throughout treatment. I'm torn between these options. What do you think I should do? This is something really common, and we've argued that this can be shared decision-making. Patients often want to know, what would you do? What would you recommend to your family member or your child or your spouse or partner in this situation? And that's okay if patients ask that and providers answer. That can still be part of the engagement process as long as you've gone through the process of explaining the need for considering preferences. Because sometimes patients may have limited knowledge, and that can lead them to say they want to defer decision-making to a clinician, but they can't necessarily articulate or form preferences if they have missing information or inaccurate information. So without acknowledging equipoise or the need for or uncertainty about options and identifying some of these trade-offs and offering patients choice, they may not be able to express their desire for involvement. But once they're informed, at least on a basic level, then they can decide how much or more or less decision involvement they want. And we've actually seen that patients, particularly with limited health literacy skills, want more involvement once they're aware of the reasons you're asking them to participate. Some of the challenges and things we're still struggling with as a field is how do we help patients articulate preferences, and how do we reduce some of the bias that clinicians can have in the decision-making process if we're doing this during consultation rooms? And what if preferences change across several conversations? So decision aids may be a way to help address some of these challenges. Explaining the complexities of decisions is really difficult, and physicians might feel that they don't have all the time that they want to spend in a consultation on this task. So decision aids may be able to help by explaining decisions in a language patients can understand, providing some detailed information about options and risks and benefits that allows it to be spelled out clearly on paper before or after a consultation. They can help patients clarify their values and maybe can document and track preferences over time if preferences are changing with new information. So Dr. LeBlanc will be talking more about the role of decision aids. And if you have questions after the webinar that you're not able to ask, feel free to email me or contact me. And I will be turning it over to Dr. LeBlanc now.
Thanks very much, Mary, and I'm going to introduce Annie. Annie is an assistant professor in the Health Services Research within the Division of Healthcare Policy and Research, and an investigator within the Knowledge and Evaluation Research Unit at the Mayo Clinic in Rochester, Minnesota. Annie's research focuses for the past 10 years have been on knowledge generation, synthesis, and its translation into practice through design, evaluation, implementation of patient-centered interventions, mainly shared decision-making interventions. She has led or contributed to over 10 federally funded, multi-centered, multi-site pragmatic trials of the implementation of shared decision-making interventions. And she held the role of scientific chair at the 2013 International Shared Decision-Making Conference and currently serves on the Shared Decision-Making Advisory Group for the Substance Abuse and Mental Health Services Administration, which is part of the U.S. Department of Health and Human Services. Today, she'll be sharing her expertise in the development of encounter decision aids and in the evaluation of their effectiveness and capacity to be implemented into practices. Take it away, Annie.
Thank you, Cindy, and thank you, Mary. Good afternoon, everyone. Before we get started, I do want to point out that I or any of my colleagues at the care unit where we conduct our shared decision-making work receive funding from any for-profit companies, nor do we receive any royalties or monetary benefits from the use of the decision aid. Moreover, all of our decision aids are available free of charge on our website. I also want to point out that I am in no way a health literacy expert, and that this talk is rather one of reflecting if, how, and in which way can decision aid, specifically encounter decision aids, addresses health literacy issues and challenges. Mary provided us with a great review and reflections on shared decision-making and decision aid overall. Before moving forward with the specific contributions of decision aids to health literacy, let's remind us of a few essentials. So in its essence, health literacy refers to one's ability to obtain, process, and understand health information. All of that in the service of making appropriate health decisions. How can we therefore better support these individuals in developing or enhancing their ability and capacity to read and write health-related documentation, make sense of numeral information, and communicate with their providers? And it matters. It matters because over a third of the population is below basic health literacy skills. And it matters because it is nearly impossible to anticipate who will have health literacy problems. Doctors themselves may have a poor understanding of their own care when problems arise outside of their specialties. I've been in the U.S. for 5 years now, and just the mention of healthcare billing makes no sense to me and I just want to crawl into a corner of my office. So, but the challenge is therefore to balance one's skills with the expectations and the demand of the system. Indeed, not only are we asking our patients to adapt their reading, calculating, or listening skills to the health context, we expect them, in addition, to be able to prepare for their appointment, watch educational videos, fill surveys, read brochures, self-measure, self-monitor, self-manage, and whatnot. And we have not even addressed the added impact of the illness itself or the state of mind one is at the time on their overall capacity, let alone their health literacy skills. And it matters because at any point in time, low or lower health literacy impacts patients' ability to fully engage in the healthcare system and impacts their health and health-related outcomes. So what can we do? Well, a few key areas for evidence-based action have been identified. The one we want to further explore today is the role of shared decision-making, specifically the potential role of decision aids and counter decision aid in addressing health literacy challenges while enhancing patients' involvement in their care. As Mary pointed out, shared decision-making revolves around providers involving the patients and their loved one in the extent they desire, in establishing or strengthening their partnership, in sharing relevant, clear, unbiased information, and deliberating toward a care plan that meets the needs, values, preferences, and goals of the patient. And to support this process are shared decision-making tools, decision aids, effective evidence-based intervention that, in a clear and accessible way, present patients with available options and their associated benefits and risks as it pertains to their health-related decision being considered. You might have seen them in the form of videos, webpage, or brochure for patients and their loved one to consider in the comfort of their home, or maybe brief cards, leaflets, or even apps to consider during the clinical encounters with the clinician. And we know that regardless of the type of decision or mode of distribution, we improve the quality of the decision-making process, whether it is increasing knowledge, decision comfort, or satisfaction. Less is known on their impact on clinical outcomes, as inconsistencies in findings remain. Very little is known on their impact on health literacy. The National Action Plan to Improve Health Literacy reminds us that everyone has the right to health information that helps them make informed decisions, and that every single encounter is at risk from miscommunication, every single encounter. I couldn't agree more. And how best to address this, and to specifically focus on the encounter itself to peer into that black box that unfortunately scares so many. So let's think about the current state of decision-making. What we have in the far left here are those three green dots, which represent the patients and providers beginning the consultations, and then addressing the health issue of interest and possible treatment. Here, let's take Medication X, for example. With the patient then leaving the consultation with a prescription. The reality is that the decision to take this medicine does not happen during this consultation. It will happen later. This far white dot on the right, that's where it happens. It happens when the patient decides to fill the prescription. It happens when they decide to actually take the medicine. So how do we work? And in this regard to the decision being made, we didn't even address, we just talked about the decision to be made. We didn't even address whether they have left with an understanding of what was discussed. And while 80% of clinicians think that patients have left the consultation with a clear understanding of what just happened, only 37% actually report so. How can we work towards bringing back the decision-making point to the encounters with the appropriate tools to address the decision at hand and assess the level of understanding of the patient? This has been the focus of our work and those of others, to bring the best evidence available, in a clear, unbiased, easy-to-comprehend way, while aligning that decision to be made with the patient's needs, values, and preferences. All shared goals of health literacy improvement strategies. So what we see, specifically for our group, we've been focusing on decision aids that surround these two principles that you now see on your screen. That our tools should create conversations, not unidirectional transfer of information. That they should be designed to address the challenges of the medical and personal situation, not the other way around. And that it represents the voices of clinicians, patients, and their loved ones. Let's see how this plays out by sharing our work around the development and evaluations of the person medication choice decision aid, where the specific objectives were to determine the ability of an encounter decision aid to translate competitive effectiveness research, CER, of antidepressant into practice, while being health literacy appropriate and enable shared decision-making and hopefully impact patients, clinicians, and practice outcomes. This was produced under a grant from AHRQ under their innovative adaptation and dissemination of products to specifically address this translation gap and adapt the findings of their work to meet the needs of the patient. How do we go about these? Well, to develop this decision aid, we first ensure that we have the best available evidence, and that's what you see on the corner left of your screen. But the best available evidence is not enough, will never be enough. We made sure that that evidence we had was representative of what our clinicians and patients experience in the encounters. If it doesn't align with their experience, we will not find value to it. We had, in one instance, years ago, clinicians that were using a decision aid in the context of a trial, and they were being video recorded. So you would think that they would put more emphasis on what they were doing. Yes, we can distinguish students, take the decision aid, and move it away from his desk to the floor so that he doesn't have to use it, because he did not agree with the information that was provided in those tools. So if it does not align with their experience, we will not find value into it. And at the same time, what we need to do is to conduct real-life observations of patients and conditions addressing this particular issue. And that's what you have on the top right, looking for important issues or elements that the literature search has missed, such as concern around cost, concern around time commitment, around the burden, how many more appointments do I need to come if I do this treatment, and so on and so forth. These are not something that you found in literature reviews, but those are issues that matter to patients in addressing this situation. So this allows us to then highlight ways by which the information is also presented. And what we do is then we work with teams of designer, patients, clinicians, shared decision-making experts, and it's not there, but we do have a health literacy expert and patient education expert that works with us. And we design prototypes that we test and retest and iterate in real-life encounters until we reach a point at which we think that it does create the most meaningful conversations. And then we proceed to that thorough evaluation. In this case, it was a multi-centered randomized controlled trials across 10 practices in Minnesota and Wisconsin. So what does this process look like? If you remember the initial CR products at the beginning of the talk. So after months of iterations, we developed what we call the set of cards that focuses not on the features of the medication itself, but rather on issues that matter the most to patients. So as you see on the top, so issues around sexual issues, around sleep, around stalking approach, around managing of their weight, around cost. And we work around how each medication then addresses this issue. Let's walk through some of these cards. I would be curious to know how many at this point, and I'm giving you maybe another 5 seconds to look at it, already figured out how it works. Relatively easy, right? So you got issues that matter the most at the top, then you've got the different options that are listed, the different medications, with both the technical term and the generic term for that specific medication. And then you can see how, and hopefully that will work, yeah. And then you can see how for one medicine in particular, how this medicine impact that issue. So the Paxil here, for the example that I have, will make you gain weight, those little plus toward the right. But it will also be difficult for you if you wanted to quit this medicine to move forward. From a health literacy standpoint, what we have is minimal wording, plain language, simple visual that allow patients and clinicians to focus on the issues of importance. And what it does is that it gives room for conversation. It gives room to include opportunities to clarify understanding or to teach back if that's what's necessary. But it doesn't prescribe what to do. It just lets you meet the need of the patients and meet the patients where they are at and work with them through that process. So, do they actually work? So, as I said, we conducted a 10-site, multi-site clinical trials with 117 clinicians and 300 patients. And what we saw in using these tools with patients with moderate to severe depression is that both patients and clinicians were more comfortable with the decision made. They were more satisfied with the process. Our patients were more knowledgeable, more involved in the decision-making process. They voiced preferences and issues of importance, and I'll come back to that because for me it's extremely important. We didn't see, however, difference in adherence or in depression outcomes. But what we did not see either is that it did not add to the length of the encounters, and that these tools were actually being used with little to no training on the clinician's part. Now, you may wonder, does this apply for patients with low literacy skill, more specifically? Well, it was designed for them. So we had about 1/3 of our population that had below basic literacy skills. And while these are very preliminary results, I do want to point that out, we can see that they gain benefits of using the decision aids while showing perhaps a slighter gain for patients with appropriate literacy skills. They're quite similar across both arms and groups. And if you look at this item number 8, the clinician, and this is out of the option scale for those that know that skill, it specifically addressed, does the clinician have checked that the patient has understood the information? So what we see is a similar number across arms and across the group, which unfortunately I find extremely low, which tells us that regardless of decision aids or health literacy skill, we need to work on these issues, as only 1/3 of our clinicians think about engaging patients in this way. Now, going back to this notion of voicing preferences, this is observations that we made in looking through the video recording of these encounters, because we video recorded all of these encounters as part of the trial. And what we see on the top, did the clinicians stated to the patients that there were more than one option? I see a great difference whether they were in usual care or decision aid. But in terms of noting whether there were interactions of health issues considered, 8% in our usual care arm clinicians did versus 40%. Now, think about some of the key principles and elements of health literacy and how we're trying to overcome some of those issues. Did the clinician actually invite patients to tell them what mattered the most to them or to choose the issue important? 0% in our usual care arm versus 62% in our decision aid arm. Were we able to help patients voice a preference for treatments? Yes. To a greater extent in our decision aid arms. And one of the things that clinicians often are concerned about, and I don't know, and you can reflect whether this happened in either your research or the practice, but it's this notion of we don't want to let the patient alone, and we want to contribute as a clinicians to that decision-making process. So did clinicians voice the preferences for treatment? Yes, 92% versus 95% in both cases. So no, we're not saying to the clinician, let the patient make their own decisions. These are made to be decided together, and this is what this slide is all about. Now, this work that we've done with the depression decisioning, we've done in other contexts, in other situations. So we've done it for diabetes mitigation choice, and we showed similar results and impact as we did with the depression work. And again, issues that matter the most to patients, and then what are the options and how these options compared across. Minimal wording, simple, visual, easy to adapt to your patient. We also have another type of decision aid, which are what we call the risk communication decision aid. And again, we didn't specifically address the issue of risk communication in health literacy. It's outside the scope of this. But in thinking about some of the principles, we can think that there is ways by which we can tailor the information during the clinical encounters to our patient's characteristics, still use plain language, use natural frequencies, and again, use the simplest of visual presentations to represent that information with them. Similar results from our clinical trials. Naturally Digital, which is online, has been currently being used over 100,000 of times over the past few months, showing that there is interest and at least face value to this tool. Now, overall, I've just shown you two examples of our encounter decisioning. And what we're showing, we've done, I stopped counting, I think we have over at least 10 completed clinical trials across setting and context and type of decision, whether it's primary care, specialty care, emergency care, hospitalization, and so on and so forth. And what we're seeing is that we are able to impact patients of all ages, that our clinicians do want to use this type of work with their patients. The added minutes to the consultation vary greatly from none to a few minutes. And our clinicians are able to use this tool without any training at all. And we're showing improvement across the board in patients' knowledge and patients' involvement. And as we showed in the initial review of decisioning, we do to show variable effect on clinical outcomes and costs. Now, I don't have specific data on health literacy across our studies, but what we did conduct is this patient-level meta-analysis of 7 of our randomized controlled trials of decision versus usual care, which comprised 731 encounters between patients and clinicians discussing treatment options for chest pain, myocardial infarction, diabetes, osteoporosis. And what we did is we examined the impact of socio-demographic characteristics, so age, sex, education, income, insurance status, on the outcomes of knowledge transfer, decisional conflicts, and patient involvement in shared decision-making. Most of our patients were aged about 65 years old. They were white and mainly women. I think it was 60% of women. And two-thirds had greater than high school education. And what we're seeing, what we're seeing on the screen is one example, and it's for the knowledge outcome. But over the board, what we showed us that compared with usual care, our decision-made patients gained knowledge. They were more likely to know their risk, had less decisional conflicts with greater involvement, and that was consistent across any of our subgroups, showing similarities of efficacy when used with vulnerable populations or maybe perhaps low literacy patients as well. So, and this is another patient-level meta-analysis that we've conducted, again, out of our trial, and this really focuses specifically on the outcome of patient involvement in that option scale, which does include questions around checking for understanding. And what we're seeing is that across the board, across our trial, we're showing greater involvement of our patients in their healthcare decisions. And hopefully, if we were to do subgroup, that would also include a similar impact for patients with low literacy. I do want to point out before opening up for questions is that what I've shown you is a few examples of our work. We also have other colleagues that do work around encounters decision aids, and this work by Jennifer Barton just been published last week. And again, this was under the same type of grant that we've received from AHRQ, and they specifically focus on low literacy patients, and they've developed this tool around rheumatoid arthritis. And what they found is that across their patients, they had about 160 patients, which most of them were immigrant and non-English speakers, and 71% of them had health literacy were in I want to use the right term. 71% had limited health literacy, and they did show gain in terms of knowledge and in terms of decisional comfort as well. So, and I know that others have shown, this is just an example of other works, and I know that others have looked specifically in decision aid outside the clinical encounters, and I would really encourage you to look at some of their work, which are showing great promises as well. But for the time being, I wanted to focus specifically on this encounter decisioning. So what could we think in terms of take-home message from this work? Well, health literacy is a shared responsibility between patients, their loved ones, and the clinicians. We need to address it in the encounters. We need to address it where it has the most potential for impact. Health information, particularly when it comes to numbers, is hard for most to understand. It's not needed to be understood outside the clinical encounters. And the main thing, again, I always think when I think of this is the story about the little prince, for those that know the Lipid's Plains, where he was so happy to have designed this beautiful boa constrictor that had just eaten an elephant, and he was showing it to all these grown-up, and all they could see was this brown hat. So I think that we can assume that people can understand information the same way that we do, and leave them alone to do so. So let's bring these parties together to make sure that they have that shared understanding. Lowering the burden to understand can also help patients engage with clinicians and healthcare decisions. So what I mean by this is, if you've seen, our tools are very minimal. And that's one point that we didn't address, is that what is needed at this point to make this decision? And so it's bringing up to the minimal information. Patient education can happen outside the encounters. We're there to make one decision. So let's bring that information to a minimal. And then there is, overall, I think that there is promising research around encounter decision aid to address health literacy gap, and hopefully we can do more of this as we move forward. So thank you very much, and if anyone has any question, I'm happy to answer, or please do email me or send me an OBS Twitter. Thank you, everyone.
Thanks very much, Annie. That concludes our presentations. And Annie, sorry, I'm going to advance the slides now. So as promised, we are giving you information for obtaining CME credits. The URL is on your screen now. And I misspoke earlier. I had said about accessing URLs from the presentation as if you had been sent the PowerPoint slide set. But you have been sent, and will get sent again tomorrow, a PDF of the slides. So you will need to copy and paste the URL into your browser. But please go here if you would like to get CME or CE credits. I want to thank everybody who has been sending questions in. We've already got a nice list here, but please keep them coming. We have another half an hour to delve into the areas that interest you the most. So go to your Q&A section of your panel on your right bottom corner. Type in your questions, select all panelists, and send it. And we will try to answer all the questions that we get. So I'm going to start with some of the questions that we've received specifically about who you do shared decision making with and how do you conduct it. So the first question was, shouldn't this shared decision-making be done for all patients and not just low health literacy patients? You mentioned, and then a second part of this question is, you mentioned that this does not take extra time during the visit. How can it not? It is great to do, but it does take extra time. And the first part of that I will start addressing, and then I'll turn it over to Mary and Annie, but absolutely, we are not the purpose of this webinar in terms of highlighting patients with low health literacy is because very often people assume that they do not want to participate in shared decision making. And there was a very interesting survey of low-income Californians that asked them whether or not they wanted to participate in shared decision-making, and people with lower health literacy, lower English proficiency were much less likely to say that they wanted to participate. But when you asked them, when you framed it, you said, well, what if the information that you were given was clear, then the percentages went way up. And not only that, the disparities between highly educated and lower educated individuals, between minority groups and majority groups, lessened. So that very often we think, oh, they're not interested in shared decision making, but that's often because they think, well, I'm not going to understand any of this. So, Mary, why don't we start with you, and particularly if you could address the question of it taking extra time or not.
Thank you. Hi. Yes, thank you. Sorry, I was trying to do the unmute. And I agree with you, Cindy, about that we should do this for patients regardless of literacy skills, and that actually some patients, even with higher literacy to start, when they're faced with a new situation or something that induces anxiety, they can lose several levels of comprehension. So this is really applicable to everyone. We just wanted to highlight some specific challenges. And in terms of it taking time, what I was referencing was studies on decision coaching, and decision coaching has not been shown in research studies to take more time. Sometimes shared decision-making can take more time in some instances, but not always. And a lot of times this is because it's a new approach to a clinical situation. So whenever somebody's implementing something that's new, it takes a little bit of time to get familiar and switch around the language that might have been previously done on autopilot. But when it becomes more routine, studies show that there are some studies that show it actually can save time, especially if you're using decision aids or decision coaching as preparation outside the visit. And it really depends on the study. So the jury is still out on whether it takes extra time and how much it would take, depending on the physician's comfort level with engaging in shared decision-making, the context at hand, the patient characteristics, and that's really true of any new intervention that we're proposing. So, Amy, I don't know if you have other things to add. I know the group has looked a lot about time.
I couldn't agree more with you. I mean, think of the first time you tried to jump on a bike, and then think about how you do it now. It's really all about learning. Any new intervention, any time we try to change people's behavior, it's going to involve a learning curve. And what we're seeing in our work is that we're showing that at the most it adds 2 minutes or so. And these are for first-time attendees. This is for the first time that clinicians are facing this tool. We give them a 5-minute training prior to the encounters, and then they have to go and use it. So in the best of situations, what we hear from our clinicians is that it is helpful, particularly in the long run. So perhaps you do have to spend a few more minutes explaining the tool at the beginning, or as Mary was saying, kind of reworking the way that you're addressing this issue. But in the long term, I mean, our patients come back with, for the depression medication, it's like, okay, we tried this one, didn't work. Oh, okay, now I see this is because of this, that, and those. Okay, let's move on. So they already are expecting this pull. Our clinicians last week were telling us that they've got the Statin decision aid, and the patients are coming in, and I said, can I see my dots? Can I see where I am at with the dots? So I think it's a learning journey, and that overall it works. Where I think that we might find added time is particularly when clinicians won't integrate it as part of their care. So they will go about their regular care, and then, oh, we've got this tool in addition. So yes, it does add to the time because you're adding a new element rather than incorporating it in the encounter. But no, unless we use it more and unless we design it so that it meets that time constraint and that we test it more, we won't know. So we need to do more to truly understand it. But the face value is that it is helpful. And even if it does add a minute or so, the value that it brings doesn't beat that minute. It's more valuable than that minute alone.
Yeah, and let me follow up with a related question that we got. And I'm going to ask both of you if you could try and keep your responses as short as you can, because we do have a number of questions that we want to get to. I also want to acknowledge a number of people have sent in questions about references or how to get decision aids that have been shown or other free decision aids. And what I propose is that we will be sending out that information in follow-up if we don't type it in the chat area while we're still on the call. The webinar today, that Annie and Mary, is that okay with you if we provide them that information when we send the slides out again tomorrow? Yes. So we will get you answers to that. But right now, I'd like you to turn your attention to this question: how can other members of the care team besides the clinician play a role in the shared decision-making conversations? How can the nurse, medical assistant, and front desk staff help facilitate shared decision-making and save time? Who would like to go first?
Mary, I can start. I think that we need to think in terms of the continuum of the journey of the patient. And throughout, like I said, for the decision aid to be used in the clinical encounters, it does mean that patient needs to have some basic understanding of their condition. So I think that we can think in terms of shared decision-making, but we can think in terms of processes. How do we make sure that they have all of the information prior to going into the encounters? How do we make sure that during the encounters they have that minimal decision-making information that they need? How do we ensure that they have support to follow up on that decisions once they've made the decisions? And I think that these are all different elements into which people can help. We have a diabetes nurse that come in, do help. They review that information with the patient. They kind of serve as the buffer between the clinicians and the patient. So I think that it's for the practice to really kind of see where, at what point in the journey the patients need what kind of information and how we can support that. But my main concern is always the mixed information that they get. Because one of the main things that we're seeing is that everyone is providing a mix of information and of different information and different terminologies to patients. And I think that that's what is at risk. Not as much as where can we do shared decision making, but how can we make sure that we standardize our process and that the patients are getting the same information throughout. And that will be a great bonus if we're able to do that and really encourage them in their process, not saying, oh, why did that clinician prescribe you this because you did that shared decision-making approach? I'll give you a better medicine, and here's how we're going to go moving forward. So I think there's much work to do in terms of how do we standardize the culture of shared decision-making and information sharing across the different healthcare team members.
And Mary, if you have anything to add, and also maybe I'll throw into the mix the question that says, the concept is great, but how can you imagine it if a physician is asked to see 40 or 60 patients a day? Can you please comment on such situations?
Yes, a lot of clinicians are concerned about that. There's a big burden in the healthcare system of so many patients and not enough time. And I would just say that if we see this as an ethical imperative and we focus on treating one thing at a time, the concepts actually apply across disease areas. So especially in primary care, for example, clinicians have to prioritize what to discuss in any given visit. You can't possibly talk about all of the possible scenarios and issues that are affecting a patient, and that's true in shared decision-making as well. But in fact, some people find that approaching situations from this perspective can actually help prioritize where to start based on patient preferences and patient implementation challenges. So you may find that a patient says, I'm just not ready to quit smoking right now, and you save that conversation for the next visit, or everything's going fine with my blood pressure medication, but I really like to talk about diabetes. So it can actually be used as a principle to even structure what to prioritize in the visit, and taking advantage of decision coaching and decision aids and things outside of the consultation can also help.
Oh, that's great. I'm going to shift gears a little bit into some of the questions about, sort of how do we get started in our organization. So I have one question from a state Medicaid agency that says, we are moving forward to make patient decision aids available on our website and marketing them to physicians and our members. Are there pitfalls you can think of in pursuing this approach? Annie, you want to try kicking that one off?
Well, I think it's outside. I think to this point it's almost outside your responsibility in the sense that you developed that we developed the best tool that are available, the one that we think that is going to be the most beneficial to patients, and we want to work toward implementing it in practice. But how they actually make use of it, there's not much that we can say to this, unfortunately. I mean, we've seen our tools being used to nudge decisions, 100 times. So I think as long as we're trying to be transparent in how we want these tools to be used and addressed, I think that's one of the...
I guess there is a question about, what kind of training might you provide in order to, to make sure that things are used responsibly?
Okay. So we've just completed, and I'm saying that as a little anecdote very quickly, but we've just developed a web tool as part of one of our AHRQ grants, where we put every training, everything that we could think of that clinicians would need to integrate shared decision-making in the practice, and we've been working on that for the past 2 years. So we've developed all kind of tools, journal club, presentation, training, and whatnot. And the reality is what we're seeing is that what works is one-on-one, and what works is their willingness to want to do something, and then their peer teaching, and others helping them work through this process. So, and I'm saying this because I think that there is minimal skills around culture and attitudes that we need to address at the practice level. But when it comes to clinicians, if they do have kind of that attitude and willingness to move into this, then the training required will depend on how complex the tool is and how complex it is to integrate it into practice. But it's going to go back to the one-on-one if my colleague is doing it in the training.
Yeah, Mary.
I would also say that trainings in groups and using the share approach to trainings and other things can be a good start, and then just track outcomes. I think that's a key aspect to this, because we're not recommending shared decision making because we think it's just a good concept. It's because we think it actually helps improve practice and clinical outcomes. And if you track quality measures like satisfaction or adherence or other things that you're interested in improving in the session, clinical conversation, patient's knowledge, and those kinds of things, it can help in the implementation setting.
Right, and so I think that there are some clear messages when you're disseminating decision aids about some do's and don'ts of how you do this. And as Mary mentioned, the share approach workshops are a train the trainer workshop, so that we will train people to then go back to their settings and train others. So those are great thoughts. So I have another question for the two of you. It says, as a board of directors considering implementing shared decision-making, what questions should the board ask of its leadership? What are the first steps? Mary, do you want to start us off on that one?
Sure. So I think to start for the first steps is to ask the board, what is it that you're hoping to improve in practice? And a lot of people will say, well, the quality of patient care. And using some of the data that we've shared and some data that's out there on what shared decision-making can and can't do and why to use it can actually help match the needs of the board with what can happen from this approach. And I would also echo the same thing I was saying earlier about tracking outcomes then based on what you're hoping to improve, and getting some patients to provide some feedback on what's important to patients' needs and care may help highlight the benefits of using this approach, since that's the goal, I think, of the organization.
Annie, do you have anything to add?
Yes, I totally agree with Mary. And I think it's really for the leadership board to not only to decide what their priority is, but to align their action with it, in the sense that one of the main barriers that we're facing is the paper performance issue. They do want to engage their patients, but they're worried clinicians are worried about the consequences of the patient not being in a setting or not meeting the performance. So we've been working in a number of practices, but I think that this is, in my mind, one of the biggest issues that we have. So not only do these leaders need to agree to what is their expected goal, but they need to be willing to make some difficult changes associated with this.
Okay.
Mary, do you have experience?
Sorry, go ahead and finish.
I was going to say, Mary, do you have experience with this as well, or how does it play out for you?
Experience with?
With the performance issues that are typical the main barriers of our practices.
Yes, and that some of that is changing with the new system moving forward, with perhaps bundling services of care and including patient satisfaction in some of these quality measures. And it's really hospital and clinic specific. And I think that does present some challenges in terms of implementation, but I don't think it's unique to this approach.
Okay. So I'm going to switch gears again, and we had some questions, Annie, on some of your research findings and about the decision aids. So I'll start off with this one. Could you discuss the relationship between greater satisfaction, participation, knowledge with decision aids and no or mixed evidence of difference in clinical outcomes or costs?
Well, I think mainly it's because we're asking too much of our data, in the sense that, take depression for example. We engaged patients in one encounter as part of this trial, and in 6 months down the road, we went back and looked at how it impacted their life. While in between, they had up to 10 different additional encounters. They perhaps went to therapy. They might have had other issues in their life happening. So I think that a lot of what we're seeing in terms of the research, and I'm going to speak of the research first, is that gap in being able to truly capture what we're trying to capture and to really be able to understand which factors are at play in that process. That being said, is our goal to impact outcomes or our goal to impact the process? And that's always where I find it, where opinion differs, is that it's impacting the process good in itself.
Great. And another question, sort of specifically on the decision aids, with medications constantly changing, how often are the cards updated? We have teams that do look out for updates on a yearly basis, and earlier if some major studies are out to play. But if anyone has any idea on how to best convey that information, because our tools are available for free, then any idea is welcome, because right now our issue is to give those new updated cards to those that are using the old ones, for which we don't have ways of tracking. Mm-hmm. And this is somewhat related, but decision aids tell you about the average patient. How do you tailor a decision aid to a particular patient situation? You know, for those who are using them with clinicians, with their patients.
I think one of the actual advantages of using tools that are done in the consultation room is that clinicians have the authority and the input to tailor some of the information. So we have to be careful that they're not trying to do so to bias the conversation. But we've seen this with our lung cancer screening initiatives at Statin Cancer Center, where we have a decision aid that we developed for in-consultation use, but we can talk about how risky somebody's smoke history really has been for them, and we can actually use a risk calculator that's done in the session to help calculate patients' actual lung cancer risk, and that can inform the discussion about whether or not screening is the right choice for that patient. And that's true of lots of aids. Option grids are another type of in-consultation tool that people have used that are frequently asked questions side by side, but the numbers and information that is provided can be tailored for individuals who have, let's say, family histories or other things that aren't captured in the aid.
Mary, you just put out a caveat about biasing, so I want to follow up with this question that we received. Are the practitioner's values part of shared decision-making?
Yes, that's a very tricky question, because I think in any two-person relationship or three-person relationship, of course, everyone's values are coming into the room during a collaborative discussion. But we have to be careful that it's not practitioners trying to change what the decision aid is doing, or what the conversation about preferences is doing. So there's someone who's often asked by his patients about, what should I choose, what should I do in this situation? And when there's truly no best option from a medical perspective, he often relates it to what kind of ice cream should I have, vanilla or chocolate. And I can't tell you what you should choose. I can tell you what I might choose based on my preferences. So it's not that practitioners don't have values, but they have to be careful that they're not trying to impose their own values on a situation that may not be practitioner specific. And patients also have the onus of implementing what's recommended and what's done. So even if practitioners feel that there's one slightly better choice from an evidence perspective, it may not actually even work for the patient.
And, you when you have a good decision made, it will not only do the risk communication piece, but it will also elicit the patient's own values. So let me ask both of you, how do you know whether a patient understands the information you give them?
I think down the line, I don't think you can really get to that point in the sense that, yes, we can't ask to, use any strategies, whether it's feedback for the patients to kind of reflect on what they've learned. But, sorry, down the line, I think that they're going to make of that evidence or that information whatever they want to make out of it. So I think that there's ways for us to prevent some of the bigger misinformation, but to which extent they incorporate this in their everyday life is going to be up to them in the long run. And I'm sorry. What I'm thinking in terms of example to reflect my thoughts is when we talk about patients and we bring up their risk information around cardiovascular events, in the next 10 years, based on your characteristics that we've just put into this calculator, your risk is 15% of having a heart attack in the next 10 years. Well, for some, they're still going to take that 15% and put it in their context, even though it is already based on that. And you say, oh, wow, all my family had a heart attack in the past. For me, this is extremely low, and therefore I'm not worried about it at all, or vice versa. So I think that regardless of them understanding the information or us trying to get down to a minimal understanding or checking of information misunderstood, there's always an inner perception that they will not convey to us, and that will be addressed later on in their personal life or their personal context.
Mary, any thoughts on how you know whether patients understood?
Yeah, there's other than giving them a knowledge measure, if you're in the clinical encounter, I would just say to use verbal strategies to make sure that the patient can repeat what they've said. And sometimes I also, if a patient's receiving a diagnosis or discussing something, even if there's not a family member or a caregiver in the room, I've often asked if they want to call somebody on their phone and have them listen in so that there's another person listening and it's not just on the burden isn't just on the patient. To remember the information, since there's so much going on and receiving a diagnosis can be so stressful. And then just having paper copies or ability to print out something you've done online can help.
And I'd like to add a footnote to that because you mentioned repeating and remembering, but to really confirm that a patient is understanding, you want to hear them describe it in their own words so that you know that they've processed it. And there's a health literacy technique called teach back, which describes how you might be able to ask those questions to confirm whether or not patients are understanding without it feeling like any kind of a test. And there's some free online training called Always Use Teachback that's available, not an AHRQ product, but very useful for those who want to get up to speed on that technique. So I want to move on to another question, which is for Annie. You had mentioned that over 90% of patient population wishes to make their own decisions about health. So our questioner wants to know, well, then isn't the primary barrier that patients are often not heard?
Sorry, I missed the first part of your question.
Right. The first part was, it says, with over 97% of the patient population wishing to make their own decisions about health, would not the primary barrier be that patients are often not heard? In other words, it's on the clinician side of they're not. And related to that, we had a question about obstacles to training clinicians to engage in shared decision making. So, can you speak a little bit about those issues?
I don't know if you want.
Yeah, before you say something, I just want to clarify because I think that statistic came from my presentation about fighting involvement.
And
actually, that's okay. It's fine. I just want to clarify the statistic because I think that it's not that 97% of patients want to make the final decision, but that they want at least to be offered choices, and it's somewhere between 90 and 95% of people, because there was 3 to 8% of people want no involvement in some of these studies. But most people want to have some level of involvement, and the level varies. Very few people want complete control or want physicians to have complete control. And it's really just about trying to figure out that balance. There are barriers to patients being heard, of course, and I think I'm of the mindset that we need to focus on training providers, because a patient can do all they want coming into the visit, but if the provider dismisses their research or their preferences, then nothing happens in terms of the shared conversation. But plenty of people take the approach of preparing patients and activating patients, and obviously I think we need both.
And that there is a power differential, and it's very hard
Correct.
for a patient to initiate that kind of activity.
Correct. That's why I focused a lot on training providers.
Okay.
Yeah,
so
I couldn't agree more with Mary.
We only have 1 minute left, and I do have other questions, but I want to check back with our web hosts. Is there any evaluation that participants need to be directed to? I'm not hearing any. So
Hi, Cindy. This is Michelle. When people exit the webinar, they will be directed to an evaluation.
Terrific. So I really want to encourage everyone to complete your evaluations. This is part of a webinar series, and we want to be in the continual improvement mode and be responsive to you, our audience needs. So with that, I want to thank our two most excellent speakers, Annie LeBlanc and Marie Politi, and thank our web producer, Tiffany, and our staff at AFIA who have helped us with this whole webinar series, and a particular shout out to Elena Fortier, who is AHRQ's lead on the SHARE approach. So with that, I will remind you that we will be sending out another copy of the presentation, and we will try and respond to the questions that we received about references and information about getting getting shared decision-making tools. So thank you all very much. I think that we had set a new record for participants with this broadcast, which you will be able to access the recorded audio in about 3 or 4 weeks. Thank you very much.
Ladies and gentlemen, that concludes the presentation for today. You may now disconnect your lines.